getting us started recording so folks can actually watch this on YouTube live as well. So here we go. Getting everybody admitted. I hope y'all are all looking forward to this presentation. I am going to switch this over so that Bethany can let folks into the meeting. There we go. All right. Here we go. Oops, I'm on the wrong slide. Good afternoon. It is right at 1 o'clock. Before we get started on our presentation this afternoon on information blocking, what do I need to know and do? I'm going to go through a little bit of housekeeping. So this presentation is being recorded. You guys will all receive a link to the recording as well as the presentation deck that we're utilizing today after the webinar is complete. Everybody is coming into this meeting on mute. We will be accepting questions. You have a chat feature that you can send questions to. So please send all of your questions through. We will be getting to the questions at the end of the webinar presentation today. We will have a few polls that we launch throughout the presentation. This is our first time utilizing the poll feature, so we are super excited. So please participate in the polls. It's how we're going to be gathering some information from you guys on answers to the questions we're going to be posing in the middle of this presentation, because I bet y'all didn't know you were going to be quizzed on information blocking throughout your presentation today. But that's the best way to learn. All right, so introductions for those of you that do not know me. My name is Sarah Badaman. I am the founder and CEO of HippoTrack. Here with me to help me in this presentation today, we have Jane Bro. Jane is our Director of Sales, and she's going to be kind of showing you guys a few features inside of HippoTrack that can actually help you with your information blocking. So if you are a client of ours, this is information you definitely want to know. If you are not a client yet, it's stuff that you'll need to hear so that you can see how we can actually help you guys out. Additionally, we have Bethany Beatty, who is our Director of Marketing, who helped us to put this presentation together for y'all. And she is moderating the presentation. So if you have any questions, you can shoot them directly over to Bethany Beatty. She'd be happy to help you out with that. Awesome. So now we're going to get started. All right, so information blocking. I'm sure all of y'all have at least heard of it, otherwise you wouldn't be here, but it is Section 4005 of the 21st Century Cures Act, and it is essentially a new regulation that is saying that any practice that is restricting authorized access or exchange of electronic health information, or EHI, is prohibited. And if you are doing it, then it is likely information blocking. So in this presentation today, you are going to learn things that constitute information blocking, as well as some exceptions that you can actually utilize if it applies. So you'll learn a little bit about that. This screenshot down here, I'm going to let Jane talk to you about it, because this is our first little introduction, not just to information blocking, but also how HippoTrack keeps you on track.
Yes, definitely. So our HippoTrack team makes sure that you stay up on top of your policies. So we'll send out a little message that comes through the platform as well as through email, letting you know that there are new policies that you need to pay attention to, or policies that need to be updated. So we will make sure that you are well aware that there is something that you need to take care of.
Awesome. All right, so the first thing is, what is EHI? We're used to PHI, right, in HIPAA, Electronic Protected Health Information, and then the Cures Act is calling it EHI. And essentially, EHI is anything that would be any data that's going to be in your designated record set, as well as in the US CDI data points, which we will go over here in just a moment. It is very important to remember that EHI is applicable to you, whether you are a covered entity or a business associate or a developer of health IT services, right? So the Cures Act or information blocking calls y'all actors. So if you're acting with EHI, then the Cures Act is for you. All right, so as promised, here are the US CDI standards. Right now, this is version 1 of the US CDI standards. Version 2 is still in draft. So these are all of the data points that must be included in your records releases for either treatment purposes or with patient request. If you need more information on the US CDI standards, there is a link there in the bottom left-hand corner so that you can actually follow what's in the version 2 that's going to be released sometime in the future for you to see. But it is very important that you familiarize yourself with these data point standards and that you ensure that they are included in your designated record set policy. You may need to update your policy. So Jane, why don't you talk about that?
Yeah, so as some of you know, if you're HIPAA check clients, we do provide policy templates when there are new policies going into play. And so this will make it very easy to manage and collaborate with your team. There's version control by each section, and you can also assign tasks to your team to make sure, again, that you guys are properly updating it and finalizing the policies that need to be finalized.
Awesome. Thank you, Jane. All right, so now we're going to have our very first poll question before we get started. Bethany, you need to launch the poll question number 1, but it is, if a patient calls and requests access to their lab results, are you permitted to withhold the information until the provider is able to review them? Technical difficulty, maybe? Bethany, can you launch the poll?
Yeah, so I've launched the poll. We've got
17%. Yes.
Oh, can you share the results?
I am. Can you not see them?
Everyone
says
can
it
see,
too.
I think, without you, Sarah.
Oh, everybody can see them except for me. Oh, no.
So 17% yes, 41% no, and 41% it depends.
Oh, so this one, everybody who answers it depends was correct. So this is one of those areas, it's going to really depend on if it falls underneath an exception. But generally speaking, if it is like general lab results, like a basic metabolic panel or a CBC, then you would not be able to hold that information until the provider reviews them. And the reason why is on the next slide, if I can get this over, is because of open notes, right? So I guess that was a little bit of a trick question because I pulled you before I told you the answer or before I gave you the education. However, so with open notes, you are not allowed to withhold any of these data points: consulting notes, discharge summary notes, H&Ps, imaging, laboratory, and pathology report narratives, procedure notes, and progress notes. They cannot be held for review. In fact, underneath the Cures Act information blocking, it says that this information must be immediately released for electronic access. It cannot be held for review. Now then, if it is something that's going to fall underneath one of the exceptions that we're going to go over later, like risk of harm, or if it falls underneath another privacy regulation, either federal or state, then you can hold those based off of the exception, but they cannot simply be withheld because your provider wishes to review the results before giving the results to the patient. Because information blocking is essentially interference with any type of release of information that is valid, right? It is important to remember if you are a healthcare IT developer that the FHIR URL endpoints, they cannot be withheld. They cannot even be withheld from your competitors because that is information blocking. They must be public information. You are allowed to charge a cost. You're allowed to educate your patients about third-party applications, but it must be factual, non-discriminatory, and focused on privacy or security risks. So if you have a concern about a third-party application, you are allowed to educate on that, and then you are not allowed to delay any access to information for no reason, right? And unfortunately, for a lot of folks, provider review of laboratory results or other diagnostic results is not a reason to withhold information unless it falls underneath one of the exceptions. All right, so we have our poll question number 2 that I guess I'm not going to be able to see, but everybody else will be, which is amazing. Your organization uploads information to the patient portal. However, you selectively withhold pushes to the portal, such as diagnostic testing and imaging results for review. Keep in mind that the rule does not require you to proactively push results and other data to your patient portal, and the rule also does not require you to have a patient portal. Just if you have a patient portal, are you allowed to do this? Waiting for the answers, and I guess Jane's going to give us the answers.
So we've got about 50% who have voted so far.
Okay.
Let's see, it's slowing down, so I'm going to close the poll. We've got, oh, go ahead, Jane.
27% yes, 41% no, and 32% it depends.
So the answer is going to be yes, this is information blocking. This is information blocking because you are selectively withholding the information. That is the key word in this question, because that is considered discriminatory, right? So if you are selectively withholding the pushes to the portal for information such as diagnostic testing, that would be considered information blocking. So when you push to the portal, you must push non-discriminatorily. And if you are withholding information from a push to the portal, it must fall underneath one of the exceptions that we're going to go through here in just a moment. All right, poll question number 3, Bethany. If another provider calls to request records on a patient, are you permitted to withhold the records until you have authorization from the patient? So this one's a little tricky because we haven't gotten into this one yet.
So we've got about 60% of people have voted. I'm going to go ahead and close the poll.
All right, so we have 22% said yes, 56% said no, and 22% said it depends.
So the no's and it depends are right? So you are not allowed to withhold information for treatment purposes until you have patient authorization, unless it requires unless it specifically requires consent from the patient, like if it's substance use disorder information. So if you're a Part 2 program or a legal holder of Part 2 information, then you would need patient consent. But if it's regular HIPAA data, then no, you are not allowed to require patient authorization prior to releasing that information. And that is because under HIPAA, we have TPO, treatment, payment, and operations, where, excuse me, it was a permissible disclosure to disclose information without patient authorization. But now under cures, it's no longer just permissible, it's required. It is required that you release that information for treatment purposes. You do not need to obtain that patient authorization, and it must be facilitated without delay. This is probably the thing that your employees are going to need the absolute most training on because they are so accustomed to doing it where they're requiring that patient authorization, and you do not want to be caught being an information blocker, because there are fines that we're going to be going over later that are associated with this, as well as a public wall of shame that you want to avoid. So training your employees to make sure that they're aware of this new requirement is going to be key. So Jane, why don't you talk about how they can actually train their employees?
Yeah, so HIPAA provides videos and quizzes on these types of topics, but this is something you can do to actually quiz your own team members. You can create a quiz question just like this and assign it to any and all users to complete. And this way you'll have that trail that you have discussed this topic with your team, and they will either pass the quiz or fail and need to try again.
Awesome. So easy peasy, they can take training through us and you can make sure that they're on it. All right, so now we're going to get into the exceptions. This is going to be kind of the meat behind a lot of what you're doing for information blocking, and what you need to be paying attention to are these exceptions, right? Because I think we can generally know we have to update our designated record set policy. That's an easy thing for us to do. We have to make sure that our employees are trained on what information blocking is and some of the new workflows like we just discussed, right? But now we have these outlier situations that we know are going to occur, and the ONC knew was going to occur, which is why they created these 8 exceptions that we're going to go through. Now then, it is very important that you create a policy on how you guys are going to be handling these exceptions. And the very first exception that we're going to go through, which is the preventing harm exception, when you are creating your policy on this, it is incredibly important, and I cannot stress this enough, that you get a multidisciplinary team together to create this policy, because not HIM or compliance is not going to be able to create this policy in a vacuum without input from clinical personnel. So from your providers, from your, maybe even your nursing staff may be able to help you with this, but you must have input here, because this preventing harm exception is you are allowed to withhold information if you have a reasonable belief that if you release that information, that it could cause real harm to the patient. So like risk of harm to themselves or to somebody else, or risk of death to themselves or somebody else, right? It does not take into account mental health or mental stress. It is physical harm that you are going to be reducing by withholding this information. And so it is going to be important that you are creating this policy and you are training your providers on how to alert the folks in your medical records department or your HIM department on how they are going to be releasing that information or withholding that information, because HIM is going to be releasing all information unless they're told otherwise, which is why it's so incredibly important, again, like hounding on this need for a policy, especially in the preventing harm exception. That is so incredibly important, and it must be a multidisciplinary approach where your providers and your medical records teams are working together. And I know that historically HIM and providers don't always get along. I remember back when I was working in the HIM department, providers saw me and they either turned around and walked very quickly away because they thought that I was going to be suspending their privileges because they hadn't signed off on all their records, or they would immediately start yelling at me. So now is a way to start building a bridge between HIM and the providers and make sure that y'all are all on the same page for this. All right, so we have 2 poll questions on this particular exception because it's so important. So if we can launch is this the 3rd or 4th poll question? Can't even remember anymore. But this is a patient has called and requested their genetic test results for a genetic disease for which there is no effective cure or treatment. Are you permitted to delay the disclosure of these test results until a provider is able to review the results with the patient? The exception does, keep in mind that this exception does not have a consideration for emotional harm prevention. And it also requires that you have a reasonable belief that withholding the information reduces the harm to life or physical safety. So this one's a puzzler.
All right, we got about 50% of the attendees voted. I'm going to go ahead and close the poll.
All right, we have 20% said yes, 59% said no, and 22% said it depends.
So I'm going to say that this depends, right? Because of the way that this question is written, we don't know if this patient has like anything that would cause you to believe that there is a risk to harm to their life or physical safety of themselves or somebody else, right? But if you were to get if you were in the HIM department or you're in the compliance department and you were to receive this medical records request as it's written, you would have to release that information, right? So unless that provider actually somehow alerts you that you are not to release the information. So good job, everybody. All right, the second of the exception to harm poll questions. A patient's spouse calls requesting records. The patient has visited your facility several times with injuries you suspect were caused by domestic violence. Are you permitted to withhold information from a personal representative you believe is an abuser? And then remember that this states personal representative. So they are a personal representative under HIPAA, which means they have the same rights to the information as the patient. So that is the key term there as a hint to you all. So are you permitted to withhold this information from this person you believe is an abuser? The answering.
All right, so we've got a little over 50% of the votes in, so I'm going to go ahead and close the poll.
All right, for you, 76% said yes, 7% said no, and 17% said it depends.
Right. So, and this is one of those things too, where if in the HIM department, you're able to see that the provider has notated that he or she believes that the spouse is a victim of abuse, this is likely not information with blocking. So you would be able to withhold the information based off of this information, right? At least until you're able to consult with the provider, let them know, so if you have a question, you can always say, I'm going to withhold this information until I talk to the provider and get clarification, and then allow the provider to tell you whether or not that release of information would cause, risk of harm to life or physical safety. So I think that the folks that answered yes were correct. All right, moving on. So the privacy exception. So we know under HIPAA, for example, treatment is release of information for treatment purposes is permissible but not required, right? And now Cures is saying if it's regular old HIPAA data and there's no other regulation that is protecting that information, you can release it for treatment purposes without authorization, right? However, we know that there are exceptions, right? 42 CFR Part 2 is one of them, right? Where it specifically requires consent from a patient to release their information for any reason, including treatment purposes. So Part 2 data cannot be shared between providers without specific patient consent is what Part 2 calls it. So that is an example of the precondition not being satisfied. So if a patient has not signed a Part 2 consent, releasing that information to that specific provider, then you are allowed to withhold that information until that condition is satisfied. So once they sign that consent form, you are allowed to release it. So this is a withholding until you get it, until you get the condition satisfied. There are other examples that folks have asked me about in this that are really specific to state regulations. So some states require specific authorizations for minors information to be released, like minor sexual health information to be released to other providers or to their parents. And so the minor has the right to actually authorize or consent for that release. That is a state law that would also fall underneath this. So if your state requires specific regulations underneath mental health records, then you can require an authorization for the mental health records as well. So that is the privacy exception. So here we have
Sarah.
another poll question. Yes.
Sorry to interrupt. Melissa Sudgeon asks, what if there is HIV information within the records? Does that fall under the privacy exception?
Not for HIPAA, I don't believe so. I think that is more of a state-specific regulation. So, well, actually, hold on, let me think about this. I've been so embedded into information blocking today that I forgot. So HIV, sexual health, no, that I believe 100% needs to be, like there is a specific authorization that's required for that. So they would need to get that precondition satisfied where they're getting that information or that authorization done for HIV records, because there are federal protections in place for HIV record releases. Does that make sense?
Okay.
Yep. So, and that's actually where you could actually release the information out, and we can actually go through that. So if there's HIV information in the record, you can withhold the HIV information only until you get that precondition satisfied, right? So, and then, yeah.
Awesome. Thank you, Sarah.
We'll talk about that a little bit. Yep. So if you are a hospital that has a Part 2 program that has treated the patient under the Part 2 program and as a covered entity, and you receive a request for another provider for all the records on a patient, are you permitted to withhold only the Part 2 data until you're able to obtain patient consent? Keep in mind that cures only applies to permissible disclosures, and the exception only applies until the precondition is satisfied. So can you launch this poll, Bethany?
Yes, the poll is launched. We've got about a quarter of the votes in, so I'm going to wait another moment.
Yeah, so it is very important to remember this only, right? So the way that this question is worded is you would release all the HIPAA information and withhold the Part 2 information until you get that patient consent. Oh, does somebody have their mic unmuted? All right.
All right.
So where do we stand, Bethany?
We've got 30 votes, 75% say yes, 13% say no, and another 13% say it depends.
Right. So the folks that say yes were correct, because this is saying that underneath the privacy exception that we just covered, you know, you're allowed to withhold information until you get that patient consent. And how this question is worded is just that you're releasing all the other information until, but withholding that Part 2 data because you don't have patient consent yet, which is exactly how it's meant to work. All right, the security exception. So this is an exception that if you were to release the information, then it would cause a cybersecurity issue for your organization. Or if you're trying to release the information and it could somehow jeopardize that confidentiality, integrity, or availability of your EHI. This must be tailored to specific security risks. So you can't just say broadly, you're not going to allow an API or allow patient information to be sent in via email because of security issues. You must really say, because of, you know, this issue, this specific issue, we will not be releasing information in this manner, and it must be non-discriminatory, right? It must be released consistently across the board. So you can't say for this subset of patients or for this subset of data, we will not release information in this way. It must be consistent across the board. This is going to be an exception that probably does not come up very often, but if it does, remember that it must be tailored to a specific security risk. All right, infeasibility exception. This is one of the ones that I think a lot of folks have questions on, right? So this is one that folks are struggling with, and it's because it's really kind of broken into 3 different exceptions into one broad exception saying infeasibility, right? So the first one, which is uncontrollable events, this is one that is kind of common sense, right? You're allowed to withhold information if you have a natural or man-made disaster, or if you're in the middle of a public health emergency, if war breaks out in the middle of the country and you're not able to release the information, right? So if your internet service provider goes down, then you can't really provide the open notes, right? So this one is, it kind of makes sense, right? So if it's an uncontrollable event, it falls underneath the infeasibility exception for uncontrollable events. If you are to utilize the uncontrollable events exception, you must provide written notice to the requester within 10 days of the receipt of the request, giving them the reason as to why that request is infeasible. Segmentation. This is the one that most people like to try to utilize, it seems, over the past month or so. So segmentation is you're unable to unambiguously segment the data that's requested from the remainder of the data, or segment out the permissible disclosures from the impermissible disclosures, right? So an example of segmentation would be if we're going to use the HIV test results, right? So if you get a patient request for information, and the way that your electronic medical record is set up, you cannot take out the HIV information for the release, then that could fall underneath the segmentation exception, right? What would not fall underneath the segmentation exception is if you scan in paper copies of dictated notes, which we see a lot of small practices do, and you get requests for information and you want to deny the request because you've scanned all the information in paper format, that would not be that would not fall underneath this segmentation request. So there's that. And again, if you're using the segmentation exception, you must provide, within 10 days, the requester the reason as to why you cannot fulfill the request. And then infeasibility under the circumstances. So this is if you are unable to provide a written record, I was trying to read and talk at the same time, so it's not that. So this is if you are unable to provide the records because you, 1, do not have access to them, or 2, you cannot release the information in a non-discriminatory way, then it is infeasible under the circumstances. Infeasible under the circumstances, we've heard a lot of folks talk through this on different webinars, and it is going to be one that is more of a delay than a flat out infeasible completely, right? Because you can actually correct circumstances in order to be able to release the information. All right, so moving on to health IT performance exceptions. This is going to be one that I think will be used. This is another one that I think is important to remember, that this is more of a delay of release of information than a flat out denial of releasing the information. So if you're going to utilize the health IT performance exception, it can only be for certain reasons, right? So if you're performing maintenance on your health IT or your internet or your network, whatever, then you're unable to provide it, and you can delay the request for as long as it takes for you to complete your maintenance or improvements of your health IT. Once the improvements are completed or the maintenance is completed, then you must release the information. If you are trying to utilize the health IT performance exception because of a security risk or a risk of harm, then you need to utilize a different exception and not the health IT performance exception. This is only for when you are making your systems unavailable or you're degrading the performance of it in order to perform maintenance or improvements to the health IT services themselves. All right, so this is another poll. If your EMR is undergoing maintenance and you receive a request for EHI while your EMR is down, are you permitted to delay the request? Keep in mind that the exception is limited in time to only the necessary time frame to improve the IT performance, and if the health IT performance is suffering because of another exception, you must use another exception.
All right, gonna wait a few more minutes or seconds. No, not gonna hold you for minutes. All right, we got about 50%, so I'm gonna close the poll.
All right, we got 72% said yes, and 5% said no, and 23% said it depends.
Right, so the yeses have it. You are permitted to delay the request while your EMR is undergoing maintenance, right? But you're only allowed to delay the request for as long as your EMR is undergoing maintenance. Now then, most of us know that it's going to be a very rare thing for an EMR maintenance to occur during our working hours. Most of the time that's going to occur overnight or on the weekends. We also know hospitals work 24/7, but HIM departments do not. So this will be an unlikely scenario, but in the event that your EMR is undergoing an emergency thing, you would be able to delay that request. All right, content and manner. This is another exception that has multiple factors, right? So this is essentially two exceptions wrapped up into one. And so when we think about this, the content is the what of what's being released, and the manner is how. So the content condition is what can be released, right? So, and I'm not even sure how this is an exception, but this is what it is, right? So for 24 months after the publication date of the Cure's Final Act, you are allowed to release only the US CDCI standard points, right? After that, you have to release all the information as EHI is defined inside of Cures, right? So that is the what. So this is saying, like, for right now, we can upgrade or update our designated record sets policy to include US CDCI standards, but then after October 6th of next year, then you have to do all of the data points. All right, the how, the manner condition, this is where I really think it is an exception, right? So if you are unable to fulfill the request and the manner in which the patient or the provider requests it, then you are able to come up with an alternative manner to release that information. If you are unable to release or to reach agreeable terms with the requester to fulfill the request, then you are able to say, well, we can't release the information then, right? Because we can't come to an agreement on how this information is going to be released. So that is the content and manner exception. All right, fees exception. This is going to be another one that is highly unlikely for a hospital or a clinic to experience. This is more likely going to be one for health IT providers, but it is essentially an actor is able to charge a reasonable fee, so long as it's not an opportunistic fee, for access to software or health IT that they create, right? So it must be an objective and verifiable criteria that is applied across the board. They can't say this hospital is going to pay this much, this hospital is going to pay that much, but that's the fees exception, that you're allowed to charge a fee. And then the licensing exception, this one is going to be, I think, extremely rare for a hospital or clinic to come into, but it may happen. But you're allowed to have a period of time where you're able to negotiate a license with a health IT provider, right, if it's necessary for you to be able to facilitate a request. So you have 10 days from the time you receive a request to start the negotiation process, and 30 days to complete the negotiation process, right? So, and if you are unable to come to an agreement, then you're not able to release the information, right? So there's the licensing exception. All right, so compliance and enforcement. So there are obviously consequences for being an information blocker, right? So there will be civil monetary fines of up to $1 million per violation. It's important to remember that OIG has not released their final rule on how the CMPs are going to be levied, but the Cures Act does allow for this. So we will update y'all as soon as we know more about the OIG CMP final rule. But we also know that CMS has included 3 attestation statements in their MIPS. So if you are a MIPS attesting organization, then you will have to attest to these 3 statements on whether or not you are in compliance with prevention of information blocking. If you are not able to attest that you are in compliance, then CMS is going to publish a list of providers who cannot attest. So this is the information blocking wall of shame. This is not a wall that you want to be on. So make sure that you are able to attest and don't lie, like really be in compliance with these rules for this. All right, awesome. Jane, you want to talk about how we can help?
Yeah, so through the HIPAA platform, you can actually email your team information about information blocking, other security reminders, any hot topics, and that way it can be sent on a periodic basis, and you'll be able to see who actually received the email and who actually opened them. There is a difference, to make sure that your team is actually well aware of what you want to remind them of.
Now, this is also really important because you don't want to be on that wall of shame and you don't want to receive a CMP, right? So now we're going to open it up for questions. So if you guys have any questions, oh, there's a lot here.
Yeah, so Sarah, do you want me to?
Yeah, can you filter these through for Jane and I?
Absolutely. And if anybody wants to unmute their mic and ask their own questions, please feel free to do so. I first want to give a shout out to everyone who read the questions wrong and answered incorrectly that way. So our data might be a little skewed. Sandra Rogue asks, how does information blocking pertain to mental health records?
Right. So again, it depends on what type of mental health record it is, right? But most of the mental health records do have additional protections. And so they would require patient authorization in order to be released. Now then, if it is a psychotherapy note, those are not allowed to be released under HIPAA. So that is important. I recently learned from one of my attorney friends, and I don't know if Erin McLean is on the call, but shout out to Erin for teaching me this. A psychotherapy note is a handwritten note that is meant for the provider. if it is scanned into the EMR, it is no longer considered a psychotherapy note. So it is important that if it is a psychotherapy note, that you keep it outside of the EMR so that it doesn't become part of your designated record set.
Awesome, thank you. SA asks, do you need to be a federally funded facility to be required to comply with 42 CFR Part 2?
No, you do not. You can be a lawful holder of Part 2 data, right? Or if you hold yourself out to providing substance use disorder treatment, then you are a Part 2, you are a lawful holder of that Part 2 information. And if you are a lawful holder of Part 2 data, then you have to comply with 42 CFR Part 2.
Okay. And then we have a couple of questions related to electronic health information versus paper-based requests. Alvin asks, is information blocking used only for electronic releases? And if so, what are the guidelines for paper-based requests?
Okay, so as of right now, information blocking is only applying to electronic health information, right? So the guidance for paper releases is still going to be underneath HIPAA, 42 CFR Part 2, your state regulations, and so forth, right? So nothing has changed for paper releases. The only thing that's changed is for electronic health information.
So going off of that, and specifically with the infeasible exception, Michael Herrick asks, how is segmentation infeasible? Worst case, you can print the information off and redact it with a Sharpie. Brenda Manning does point out that these are, of course, only for electronic records, but then Michael retorts, wouldn't you have an obligation to your patient to print it out for them?
Right. So, I mean, and this is getting down to, okay, so Brenda's right? So printing it out and then like taking a Sharpie to redact the information is not electronic, and it's not an electronic exchange. So it's therefore not covered by this, right? The ethical question of whether or not you have an obligation to print the paper for the patient, that is really going to be your own organization's policy versus a regulation of what's required. So I think that you need to consider also, if it is a patient request, that a patient has access to their information, and I don't know what you would be segmenting off from the patient unless it's for risk of harm, or if it's something that it's not, like they're not allowed to see, because we also need to make sure that we understand that the patients have a right to access their own records.
Great, thank you. Let's see, Janet MacArthur asks, is it considered information blocking if a physician does not complete the discharge summary, operative notes, etc., in a timely manner and the patient is requesting that document?
Okay, so this is going back to my days in the HIM department, right? So the information blocking rule is clear that things need to be done without delay. And so physicians not signing their records is going to be a big problem for hospitals. It's something we already struggle with, right? In getting physicians to sign off on the records and getting those done in a timely manner. And so what really needs to happen so that you don't become party to an information blocking citation is you need to really go back in and work with your providers and, you know, ensure that they understand that this is no longer just a billing compliance issue. This is no longer just a documentation compliance, you know, it is for a CMS rule, and now it's even information blocking. Like there's so many different layers that are relying on them to sign off on those records and get them complete and final in a timely manner. And so you need to discern for your organization what a timely manner would be. You know, is it 5 days from discharge? Is it 10 days from discharge? And make sure that it is not without delay. And if it goes beyond the use date as your reasonable time frame, that the provider has a reason and not just they're busy for delaying that, because it would 100% cause an unreasonable delay because the providers aren't doing their part. Because it's very important that this is, like every hospital, it takes all of our moving pieces, all of our moving parts to make it work, and the providers do have a role that they have to play in compliance. And now that information blocking is here, it's just reiterating the importance of that role that the provider plays in compliance.
Awesome, thank you. The last question we have in the chat comes from Amanda Gomez. Who can be considered a personal representative?
Anybody that a patient designates as their personal representative. So a personal representative is somebody that is specified by the patient, right? So a parent, a spouse, a friend, a caregiver, a neighbor, anybody can be a personal representative, but they have to be designated as a personal representative under HIPAA in order to be there. So, yep. All right, so if we have time for a few more questions, if there are any more questions, Bethany.
Sarah Parthavi, I got a comment more than a question.
Hey, Parthav.
Hey, so I can understand the exceptions, but my biggest concern is if that exception needs to be utilized due to your negligence, right? And it could be any of the exceptions,
yeah,
which could kind of your absolute negligence. And this comes back to your risk acceptance. You can splice this as negligence or accepting the risk, right? So
right.
it becomes a bit complicated. So my question then is, this gives people air cover for not doing what they're supposed to be doing too at the same time. You see what I'm saying?
I do see what you're saying, right? Because you can have, like, for example, if you're a victim of ransomware and you cannot access your records, you can say that it is an uncontrollable event exception under infeasibility, but do you have that ransomware because of things that you accepted, your own negligence? Or, yeah, I can understand that concern. I don't know how to address it, but I do think it's a valid concern for us to consider.
Right, and no, that was just a comment because I for me this is a big red flag in some ways, because there are tons of exceptions you can use which could be used in the improper manner, and there's no way that you can really prove it, right? You can't. So just a note, but hopefully we can address this and get some accountability in there. So, okay.
Yeah, no, I agree. I wouldn't know. I mean, if anybody has any ideas on how to address that, that's actually worthy of discussion. I like that idea, or that comment rather.
Okay. That was it from my end. Thank you.
Thank you.
Thank you so much, Parthav always makes us think.
Sandra George wants to circle back to the psychotherapy notes. They say they're a little confused on the indication that psychotherapy notes are always, oh, I'm sorry. Let me read it word for word. Are you indicating that psychotherapy notes are always handwritten only? If so, they would not be considered an information blocking as they are not electronic. If they are added to the EHR, are you indicating that they are no longer considered psychotherapy notes and are now part of the designated record set?
So that was, yes, from what we were told by another compliance attorney, I'm not an attorney, by a compliance attorney, is that once the psychotherapy notes are scanned into the EMR, EHR, they are part of the designated record set and are no longer classified as psychotherapy notes. Psychotherapy notes do not live inside of the EMR or EHR because they are meant only for the use of the therapist themselves. They are not a diagnostic tool. They are or diagnostic information. It's not anything other than information that the therapist needs in order to continue treating the patient. So once it is included in the EHR, EMR, it is no longer a psychotherapy note. It is part of the designated record set.
So it doesn't have to be handwritten only. It can be electronic as long as it's not in the EHR.
Yes, that's true. Yes. So, but it's also very important to remember that a psychotherapy note is not a note that a therapist will write on a patient. It's very specific, right? It's like, Sally came in today, these were the things that we talked about. Oh, when Sally talked about this, she looked up and to the left, wonder if she was, being disingenuous. Like those are the types of things that are psychotherapy notes. They're very, very specific, a very specific type of note. A lot of times folks will think that any note that comes from a mental health professional or a therapist is a psychotherapy note, and that's not true. A psychotherapy note is a tool that a therapist will use during a session, and they will refer back on those notes later on. It is not the note that would even need to go into an EMR.
So Michael says that he has a client with a specific policy stating that certain documents may be stored in EHR for convenience, but are not part of the designated record set. Would that, like having that policy in place, exclude it from that?
I think that becomes part of a slippery slope. I think that there are documents that you can store and you can keep out of your designated record set, which is why we have a designated record set. But if they're stored inside the EHR for convenience, I guess I would have questions, right? Because then, is it part of your legal record set then, right? What is it? When it's part of your EMR, it's some sort of record set. And having a policy that states these types of documents are not in our record sets, I don't think is going to be sufficient, right? And trying to think of reasons as to why. So if a patient calls and requests for their whole record, oh, go ahead.
I'm curious about it. I mean, we know this was kind of a creative solution. The idea was, the EHR is still a convenient place for storing documents, but this is a case where they do some social services and coordinate with like rental assistance and stuff like that. And so they have these documents that pertain to somebody who is a patient, but they're not healthcare documents. They're not PHI. They didn't want to create an impression that they're PHI just because, for convenience sake, they're storing them in the EHR. To me, the determination of what's a designated record set is separate from any technology question. That was the theory behind this policy. I don't know.
Yeah, I don't know. From a personal opinion and a personal preference, if I was at that organization, my recommendation would be not to store that type of information in an electronic health record system or an electronic medical record system, because what if there's a merger or acquisition? Then who owns that data, and where is it really supposed to be in the EMR? Like if they're just selling off the patient record, if they decide to retire, if it's a small type of practice, and they're selling off those records, that's something. Then if you get a request or if you get a subpoena for everything inside the EMR, and then you're releasing, it just becomes such a slippery slope, and I know all these what ifs are like way outliers, but they're things that need to be considered. And I would strongly suggest coming up with a different documentation system for that type of situation. I would not have that as part of the EMR.
How about an extendable EHR that lets you use APIs to connect to other storage systems? That would be cool.
Yeah, I wonder if something like that exists. Yeah, awesome.
Thanks.
No, thank you, Michael. All right, so we are running out of time. If you guys have any other questions, if you could please email them to us. Mine and Jane's email addresses are on the screen. I want to thank you guys all once again for attending another webinar put on by HIPAA Track. Remember that compliance is quality patient care, and we look forward to seeing you guys again next week, right, Bethany, for the HIPAA huddle? Isn't that on the 16th?
Yes, I believe so.
Yep. So, and I know that we'll be sending out information on that as well. So thank you all so much. Have a lovely rest of your day.
Everyone.
Thank you.